Hello everyone, this is Nityashri. I am a pre-doctoral fellow at the Institute of Public Health in Bangalore. Welcome to the 13th webinar of the Equilogues webinar series. Equilogues is a series of webinars organized by the Health Equity Network India with its secretariat at the Institute of Public Health. We conduct webinars on varied topics of health equity research interest once in 2 months. Before we begin the session, I will go through a few house rules. The presentation and the question and answer sessions will be live. Participants can hear the speaker but not respond or ask questions verbally. You can type in your questions or comments in the chat box accessible through the controls in the bottom of the Zoom window. The speaker will make their presentation, following which they will address as many questions as possible within the time available. Today's webinar is being presented by Rajalakshmi RamPrakash. Rajalakshmi is a researcher and a social activist on gender and health based out of Chennai. She has a master's in social work and a doctorate in social sciences from Tata Institute of Social Sciences. She has been involved in several research studies on themes intersecting gender with sexual and reproductive health, law, ethics, health insurance, and health systems. She is a member of Jan Swasthya Abhiyan, Gender and Evaluation Community, and is currently with the Loyola Institute of Business Administration in Chennai. The topic of today's webinar is Gender Inequities in Publicly Funded Health Insurance Schemes. In this webinar, the speaker unravels gender inequities in social protection mechanisms for health and challenges the gender neutrality stance of publicly funded health insurance schemes. She discusses the several gender-based barriers in the pathway to access healthcare under the PFHIS, drawing from her recently completed doctoral study on Tamil Nadu's Chief Minister's Comprehensive Health Insurance Scheme. Concepts such as household, access, and coping are revisited using a gender lens. Now I will hand it over to Rajalakshmi, who over the course of the next 20-25 minutes will take you through her presentation. I request you all to note down your questions or type your questions into the chat box. They will be addressed at the end of the presentation. Over to you, Rajalakshmi.
So in today's presentation, we will first look at what is gender equity in health and its components. And we will also look at what is universal health coverage, how do we understand it in a more broader way than the traditional definitions, and see how gender equity is linked to UHC and publicly funded health insurance scheme and the different understanding that is there in the global context. Then I will take you through some findings from my doctoral study on gender inequities from the study of Tamil Nadu's Chief Minister's Comprehensive Health Insurance Scheme. Then we'll go beyond the disaggregated findings to understand from the narratives of the men and women. Finally, we will revisit some concepts that are often taken for granted in discussion of health insurance schemes like household coverage, coping. I will also have a slide on the gender implications of Ayushman Bharat and a few suggestions for future research, and hopefully we'll have a good question and answer session. So what do we mean by gender equity in health? Now, I'm hoping all of us to understand, know the difference between equality and equity. And in the context of gender equity, it's a bit more complex because arriving at the presence or absence of gender equity brings in the whole set of biological factors which interplay with social, political, and economic cultural factors. And they create like not just 5,500, but like millions and shades of gray, which is then very difficult sometimes for a researcher to disentangle and find out the effect of each of these. So it's important to understand that health inequities reflect not only in terms of mortality, morbidity, or such health outcomes, but health inequities can also decide the allocation and distribution of healthcare resources, their access and utilization, and the social determinants of health and its distribution among the different population. Therefore, a more practical understanding of gender equity in health would be what Sen and Oslin have proposed: the elimination of avoidable, I also add systematic, differences between men and women, ensuring that equal access to healthcare resources are there for equal need, which is horizontal equity, and for additional resources for unequal need, which is the vertical equity component. Now, I think this is something that we all understand, but sometimes it's good to lay it down, that men and women have respond to health differently based on predisposing factors, their health vulnerabilities, exposure to different kind of risks along the lifespan of men and women, and their own perceptions of what is the health need might differ. The severity and consequence of illnesses also might differ between men and women. The experiences of ill health and access to healthcare resources, how treatments make an impact on their own health, and the response of health systems. All of this create a myriad of factors and picture. So this has to, even though they look very simple, but while making a policy response, often some or the other get missed out. Now, I will go to the definition or understanding of universal health coverage, and I consciously choose not to use the UN definition, but the high-level expert group's definition of universal health coverage, which has components of care, coverage, and also protection. So, universal health coverage would mean there is equitable access to all citizens, irrespective of income, social status, gender, caste, or religion. It includes ensuring affordable, accountable, and appropriate health services of good quality. It means that most health services are to public health and which addresses the wider determinants of health on individuals and populations. And it also requires that the government be the ultimate guarantor and enabler, but not necessarily the only provider. So it is with this kind of understanding of universal coverage that we need to look at publicly funded health insurance schemes or any scheme which come under the UHC umbrella. So what do we know about gender in universal health coverage? Now, there are three schools of thought about UHC and equity. One school of thought says UHC is intrinsically taking with itself equity goals also. Therefore, they both go together in the same direction and one ensures the other. The other school of thought thinks that unless we make explicit efforts to reach to the most marginalized groups, UHC may not ensure equity. And there's a third group of people who feel that, in fact, while we aggressively pursue UHC goals, there is a tendency for new forms of inequity to come in, and inequity might actually be exacerbated. So, still there is debate and discussion on this, and there is no clear policy documents or response as to how to implement or design or check, monitor, evaluate a UHC program vis-a-vis equity indicators. In terms of gender equity and UHC and PFHIS, so far the studies usually have been coming from the micro-insurance sector or the community-based health insurance sector. And even if it has focused on gender, mostly it's on removal of user fees and how it has impacted maternal and child health indicators. But the most dominant form of UHC mechanism, which is right now the large state-sponsored public-private kind of arrangements, the aspects of gender in this are just starting to emerge. So literature review, as a part of my doctoral study, revealed that equity studies in this publicly funded health insurance schemes in India studied more along income profiles, urban-rural locations, scheduled caste, scheduled tribes, and the non-scheduled caste groups than on gender. And if gender is discussed in PFHIS studies, it's usually, as I said, on maternal and child care services or sex-specific kind of services like hysterectomy or cervical cancers. And often gender gets attention only in hindsight. After a scandal of hysterectomies, I think the whole community, research community also woke up to the fact that, in PFHIS, we need to look at gender more seriously. And in terms of processes and impact, except the fact that women consistently have lower awareness on health insurance compared to men, The results on enrollment or utilization and financial protection swing either way. Some studies say that women fare better, and some studies say women don't fare as well as men. And most of them do not explain why. The reason why we see certain patterns even in the literature on PFHIS and gender is that because everything is measured at the household level. There are studies even which measure awareness at a household level, enrollment at the household level, and also the indicators like financial catastrophic health expenditure is often discussed in the household level. Therefore, if at all we have a gender differentiated indicator, it's restricted to female headed households. So this is a main reason. The other reason is that most studies use the WHO's Magic Cube framework to understand and describe and analyze any universal health coverage scheme, including PFHIS. So the Cube framework itself sometimes has its own limitations in terms of rendering itself to equity-based analysis. And also most studies are purely quantitative, use quantitative methodologies looking at NSSO data or IHTS data or claims data. And very few of them are mixed methods which use qualitative methodologies. And we know that gender issues are likely to come up when we use at least a mixed method research. So there is this vicious cycle of we have less evidence on gender, and therefore it is not seen as an important aspect of access of stratification in terms of health insurance schemes, and there is less priority given in exploring gender. Nobody starts looking out or sets off looking out for gender issues in all the dimensions of the health insurance schemes. So now with these kind of research gaps, the doctoral study looked at gender analysis of the Tamil Nadu Chief Minister's comprehensive health insurance scheme. Now, for those of you who don't know about Tamil Nadu's health sector, we have both a very robust public health setup coexisting with a strong private health setup. And both as lately as few months ago were unregulated. We have a Clinical Establishments Act, but it's not yet implemented. And inpatient services in Tamil Nadu are mostly served by the private sector, and most of it is financed by households. So you can, and the cost difference between a public health setup and a private hospital is sometimes like even 50 times for the same kind of a hospitalization. The Chief Minister's Comprehensive Health Insurance Scheme is very much on the lines of the Andhra scheme. It was introduced in 2012, and all household members, this is where it differs from the erstwhile RSBY, all the household members are supposed to be enrolled once the household is enrolled. It has a huge network of private hospitals. It also has a strong network of 56 public hospitals. There are around 1,000 odd procedures that are covered under the scheme, and 56 are reserved. Now, these reserved procedures mean that either it has been shown to have a lot of moral hazard or provider-induced utilization, and therefore now they have been restricted only to be accessed in public hospitals. And it also has all these low-end kind of surgeries and treatments which don't have very high revenue, so they are kind of the private hospitals are not interested, and therefore they have been assigned to the public health hospitals. And under the scheme, within the public hospitals, we have separate wards called the ward number 500 to treat those patients who come to the public hospitals with the CMCHIS card. The scheme has a 24/7 kiosk method of enrollment. It has a 24-hour helpline. So what were the key research questions of this study? It was to understand to what extent has the scheme helped women in Tamil Nadu to address the different barriers to access healthcare treatment and provide financial protection, and the extent to which the scheme in its design or implementation and impact has it facilitated gender and health equity. So the study methodology and methods. For the first phase, it involved analysis of the latest NSSO round the central sample of Tamil Nadu. It also involved analysis of the claims from the insurers for a period of 3 years, 2012 to 15, which involved around like 9 lakh of claims. Also looked into the websites and policy documents of the scheme. In the second phase, there was a household survey. 2 impoverished localities, one from urban Chennai and one from rural Salem, were purposefully selected. And a house-to-house survey was conducted, covering around 1,200 households in all total. And the third phase of this research involved in-depth interviews with 33 hospitalized women. They may or may not be enrolled. They may or may not have used CMCHIS for their hospitalizations. Similarly, 16 interviews were conducted with women and 14 interviews with stakeholders. So now we'll get into some of the findings from the study. First is the establishment of vertical and horizontal equity. To make any judgment about whether there is equity or inequity, there was a need to first understand what is there. So I looked at the NSSO data, and when I looked at the inpatient-related indicators, I also tried to remove all the hospitalizations related to the childbirth. Now, the reason for this is that the study was looking at financial protection for inpatient care through the CMCHIS. And in Tamil Nadu, we have a very excellent network of services for maternal and child health. And we have this Dr. Rajalakshmi Maternity Benefit Scheme, which takes separately offers the financial protection for expenditure related to that. So therefore, by removing hospitalizations for childbirth from this overall aggregate indicators, some interesting patterns emerged. One is that hospitalization rates, which were higher than men, reduced and equal to that of men. This means men and women were both accessing inpatient care for sex-neutral conditions. Of course, a small percentage of that went into menstrual and gynecological issues, but it established the need for men and women for other than maternity to access healthcare. Second is that the share of the public hospitals among the women reduced, which means women were accessing for the non-MCH kind of hospitalization more of the private sector. So this means the risk of catastrophic health expenditures. And if you looked at health expenditures for men and women, and if you remove hospitalization there again, the expenditures increased for women for hospitalizations which did not involve maternity and childbirth. So this sort of lay the ground of what could be the risk factors for women for facing catastrophic health expenditure, and what should policy response therefore look into. But if you look at the reasons for hospitalization, again based on the NSSO data in Tamil Nadu, you find on the top for both male and female, fever as the most important reason, but CMCHIS unfortunately does not cover secondary small hospitalization for secondary care treatments. If you see the right column, female, you'll find cardiovascular diseases being the second most important reason why women are getting hospitalized in Tamil Nadu. Often heart diseases are understood to be seen as men's diseases. And here we find that it is the second most important reason for hospitalization among women. Cataract. Now again, then one has to try and understand if cataract is a more sex-specific reason for being the third most reason for hospitalization of women, and what are the other socio-political cultural determinants which puts it as the third most important top-rated reason for hospitalization. So, and then menstrual and gynecology, which is sex-specific, comes as the fourth reason. On the left, you find the second most important reason for men to get hospitalized were accidents and injuries and road accidents. So this again has a gender implication because of high risk taking, because of the nature of work which puts men at risk to be victims of road accidents. It also implies gender-based norms which looks at where violence is more accepted form of response for men. So, and then cardiovascular comes in. So, at least in the context of Tamil Nadu, the policy has to try and address these kind of different gender-based reasons for men and women to get hospitalized. So this is I'm just sharing only a few tables or findings from the study. If we take differences in terms of health expenditures and financing, consistently you will find out-of-pocket health expenditures to be lower for women compared to men. This is not a cause for celebration, but actually what it means, if you take into consideration the total health expenditures, you will find that also is very low for women compared to men. Therefore, when you deduct all the other reimbursements, etc., you find out-of-pocket expenditures to also be low. And there have been a few recent publications which also talk about how this pattern is pervasive, even if you control the ailment for which men and women are getting hospitalized, and also for the length of stay at the hospital. So this very clearly brings out a gender discrimination in terms of healthcare resource allocation. If you look at differences in how, what are the sources of financing or coping with these expenditures, you will find that female hospitalizations often rely on the contributions from friends and relatives, whereas the male hospitalizations involved more borrowing, which means more leveraging through formal loans and credit, etc. So distress financing, therefore, gets associated more with male hospitalizations, whereas not for the women's hospitalization. So overall, you get a picture that there is definitely a differential allocation of healthcare resources. So now let's move to the claims coming from the Chief Minister's Comprehensive Health Insurance Scheme, which sort of reflects on utilization. We know that the whole household is enrolled, then the entire, all the members can access the scheme. But we find that in spite of comparable enrollment rates from the NSSO, we still find the claims to be largely from men. So the proportion is 64:46. And in terms of the total claim value, the male take the largest piece of the cake, and it's almost double the share of women's claims in the total claim amount. So this is when it is not disaggregated. Now, if you try and disaggregate this data along age and also the type of hospital, you will find other interesting patterns. You will find, like in the graph where I have circled, from the age of 35 to 44 alone, the female claims overtake the male claims. And also, if you divide these hospitalizations into public hospitals and private hospitals, again, in public hospitals, the aggregate trend of men overtaking women gets reversed. Here you find more women than men hospitalizations which have raised these claims. So this brings into the question of why is this 35 to 44 being overrepresented compared to the other ages? So one of the findings was that it is because in this age, the hysterectomies are often done on women, and because of the background that we already know that hysterectomies can be imposed even when they are not necessary, this raises a new question as to where these all rational and appropriate hospitalizations. So many studies usually stop with just gender differentials using large sets of survey data or secondary data. But for gender analysis to be complete, one has to go beyond these gender differences. We need to understand what explains this lower utilization of CMCHIS by women, because hospitalization rates are equal, enrollment rates are equal because the whole household is enrolled. And what processes actually leads to inclusion or exclusion of women in CMCHIS? And given that we have an understanding of the kind of ailments leading to hospitalization and how there is not much resource allocation. Has CMCHIS addressed these kind of health needs, addressed the inequities that we already know that exist, and also the question of, are there new forms of gender inequity that are being created by this health financing strategy, which can be seen either in the design or implementation of the scheme. So this is where the household survey and the women's narratives really help to identify the barriers. So we have Naila Kabir's framework of gender-based barriers, which I used as the gender analytic framework to understand the different findings coming out. On one hand, we have what is called as gender-specific barriers. These are barriers which are closely related to biology and notions of femininity, and usually they are experienced exclusively by women. Because of women's contribution in the reproductive role, the burden of childcare, for example, often gets associated and expected out of women alone. So this is an example of gender-specific barrier. If you take gender-intensified barriers, this affects both the genders, both male and female, but it can seem to be affecting more intensely on women. For example, lack of awareness, which leads to lack of enrollment or being a victim of provider-induced utilization. The third category is gender-imposed barriers. These are institutionalized norms. They could be written or unwritten, but they have clearly a bias against women. For example, say son preference, and therefore its reflection in the property rights. So I tried to call out the different barriers that were coming from the narratives of men and women and categorize them under these three categories. So I will take you through some of them. If you look at gender-specific barriers, we find that a range of sexual and reproductive health services are not present in the CMCHIS design. MTPs, contraception, infertility treatment, breast and cervical cancer screening, mental health problems, gender-based violence or HIV treatments are not explicitly included in the services. What we have is high-end treatment for cancers. We have hysterectomy, but now women have to go to the public sector to access it, even if it is a rational, appropriate service that is needed. And often what is included is something that is very technology intensive, like eclampsia, which is an important cause for maternal mortality, can be claimed under the scheme only if a ventilator is used. So what happens is that the district hospitals which do not have ventilator facilities will never be able to take help from the scheme for the women in this case. The second important barrier that came, which was gender specific, was that women were excluded from enrollment because of patri locality. That is, to access the scheme, one's name has to be present in the ration card or the PDS card. During the time of data collection, because of the digitalization of this PDS card into a smart card, new enrollments new inclusions into the PDS card were stopped. So women who had married and shifted their residences to their husband's home, their names were struck off from the maternal home card, but they were not yet included in the new card. So there's this whole set of women in a prime reproductive age who were being systematically excluded simply because the scheme insisted on the ration card and did not allow any other form of identity card to enroll in the scheme. And also another form of exclusion for women because of this understanding is that women who don't really belong to the husband-wife dependence kind of framework, like women who have been deserted, who have walked out of abusive marriages, who are second wives of men, sex workers, they do not usually settle down in households that are typically there in the imagination of policymakers. So most of them also may not have the PDS card. So this was leading to an exclusion of a substantive number of households. The third most important gender-specific barrier was that the burden of unpaid care was enormous on women, and it was an area in which there was no expectation of male participation, and there was a need to take permissions from spouses and other important powerful family members. And if the women did not find a lack of support, if the women did not find support to replace her and her activities and her role in the family, her hospitalization was getting indefinitely delayed. For example, a woman who had uterine bleeding for many months said that there's nobody to look after me. I only have 2 sons and my daughter is married off. So finally, she had to wait for the daughter to come back and take care of her. And the sons or the male members in the family often not trained or expected to take care of the care work in the house. So this was a major barrier for women to seek hospitalization. It is also a barrier for women to go and stand in the enrollment camps and get their names included and get enrolled, or attend an awareness program that is being conducted in the neighborhood. And even if, say, there is a supportive family structure and the woman even has a card, the internalization of gender norms, which makes the woman feel very guilty to use the household resources for her own health, makes it difficult for them to actually utilize the card. So women feel that it is better that the card and its benefits are rationed for the other family members like children or the spouses. And there is this delaying and replacing inpatient treatment with just outpatient care. They will just go get some tablets from the pharmacy and delay simply because they feel they cannot handle the burden and guilt of having spent a substantive amount of their household resources for their own health. Now let's look at some of the
gender. Rajalakshmi, hi, this is Nityashri.
Yeah.
We don't have too much more time left for interaction. So if you could maybe go through the next few slides quickly, we can take questions. I'm sorry to interrupt you.
Okay. Yeah, no problem. So intensified barriers, for example, awareness among women because of poorly done IEC programs, because it was actually the insurer who had to do it, who have profit motives, not welfare motives. So you find the remote localities in the rural areas or even the urban poor being excluded. And if you look at tertiary care services in the rural area, even for accidents or cardiovascular emergencies, they have to travel like 55 kilometers to seek these care. So there's an inequitable distribution of these services, and over that there is a scheme which actually doesn't lead to any impact. There is cherry picking by providers, by which they sometimes, to refuse a case, give wrong information and misconceptions, which quickly spreads into the communities. And even if CMCHIS is used, in these hospitalizations, you find a lot of delay and out-of-pocket expenditures, especially in the private sector, which makes these citizens feel that CMCHIS is not useful for emergencies. So the cashless nature is totally not visible in the study that came out. And depletion of assets. Usually you find it's the women's jewels that are being used to meet her health expenditures, even if it is not for her own hospitalization, for the others. And it's the girl children who give up their education, or the women taking up more houses for domestic work to meet with the healthcare expenditures. So irrespective of who is hospitalized inside the house, the burden seems to be unduly falling on women's shoulders. The most important here I would like to focus is that public hospitals have also started using insurance as a revenue mechanism, and therefore they have also started discriminating patients who don't have CMCHIS card and those and patients who have certain needs which are not covered. I mean, the treatment that they need to have is not a covered package under the scheme. So in terms of imposed barriers, the whole idea that a household is egalitarian and all resources are distributed equally, or all burden is distributed equally, results in policy responses where one card is given for a family. So the woman who has been abused and has come out of the home cannot go back to her husband's house and take the card and use it. And also this idea of that if a household is economically well off, the women will also get an equal share, also makes financial protection policies to exclude the middle and upper income quintile. And there could be intra-household differences there where women are not able to access or pay for their own healthcare. And the imposition of care work on women has translated into policies in the hospitals, for example, which insist on a female attendant if the woman has to be hospitalized. So there have been cases of many women who have not been able to find another female in their household or support networks and not being able to access healthcare at all. And in general, we find that state policies focus on mothers. Mothers attract better attention in terms of resources. We have maternity benefit entitlements and better services very close to the communities. But we have women facing cardiovascular issues, high on diabetes and hypertension, but services for such horizontal needs are largely absent. And I think even research community has sort of contributed to this gender inequity paradox because of lack of equity lens in the way in which they have addressed the issue of health insurance and its impact and processes. So everything is captured in the household level, and data that is kept in the scheme with the insurer is not suitable for disaggregation or for any kind of equity analysis. So it's important to understand what do we mean by a household or a family. So it's a social protection policy, but it has just taken the definition from an insurance policy language meant for private Mediclaim insurances. So when an unwell woman is sent to her mother's house to be taken care of, the expenditures happen in that home. So my question is, how does economics try and capture these kind of power inequalities that we observe? And what about sex workers or transgender persons who don't have typical households? And is coverage enough to convert into utilization? And is all utilization appropriate and rational? And therefore, where is access? And all barriers need not be financial. For example, the very thing that we need a female attendant to get admitted in the hospital has had grave consequences, which is a social barrier. And distress coping, we say that households sell assets, but whose assets are we talking about? So why should the youngest daughter-in-law give her jewel for the father-in-law's hospitalization? So even within the household, you find that the different negotiating power playing a role as to whose assets get depleted when there is a catastrophic health expenditure. So I would like to summarize by saying that the pathways of access for women are vastly different from men, and within women you have different other intersectional variables, and these have to be thought through in health policy responses. And we have an inequitable health system already, and now this PFHIS, which are based on market-based ideologies, are now leading to further exclusion and discrimination and disempowerment. So in the studies analysis of whether PFHIS is gender neutral, yes, the language is gender neutral, but it is set in an unequal patriarchal society, and market ideologies are dictating about health policies and health systems. Therefore, it basically translates into a gender blind policy. And therefore, UHC schemes have to have a very explicit attention on gender, on marginalized groups. Otherwise, the path to equity is likely to be challenging. So I end here.
Yes, thank you, Rajalakshmi, for the presentation. What we could do now is there are a couple of questions from the participants. We can take those, and I don't think we will have time. I'm sorry for all the technical difficulties that came about despite preparation. So maybe we can take some questions now, and then we'll see how it goes.
Yeah, sure.
Sure. Okay. So so the first question is from Tanya. She asks, she says, you asked the question of how the scheme may be exaggerating or creating inequities. Were there instances where the scheme mitigated the existing inequities in accessing health services?
Yes. Sometimes the only choice for the woman is to seek healthcare through the CMCHIS. So, in fact, there was a case of a woman who first used the CMCHIS card in private sector, and then she learned about this insurance ward within the public health sector. So, she found that the out-of-pocket expenditures could be much less when it's a public hospital. She felt they are more accountable to the people, to the patients. So then she used, for her second surgery, she used her card in the public hospital. So here again, I find that if women can plan their hospitalizations, yes, there is a scope for the scheme to help out if it is one of the covered surgeries. But for emergencies, usually they are not. A few instances where women have benefited through these health camps that have come to right into the villages. So the women do not have the scope and time to go to the private hospitals which are in the urban areas. So the hospitals conduct health camps closer to the vicinity. Sometimes there have been cases where women have used the camp method and then got financial protection under the scheme. So if you look at micro cases, yes. But if you zoom out and see the overall picture and how it is eroding the public health sector where women are accessing more, then then it's a different picture that emerges.
Mm-hmm. Okay. Thank you. So next question is from Gayatri. She says, what plans, if any, do you have for your findings reaching the powers that be?
Okay. Basically, I'm quite happy to say that at least in the research circle, this study is being used and appreciated. I have also presented the study with the state government of Tamil Nadu to the CMCHIS project director and to the NHM director. Of course, there were areas of argument and disagreement, but now they have also agreed for me to help in revamping at least their MIS so that we can make analysis based on equity. So I have had an entry point now with the state government, and I have written also widely in the common media, in newspapers, e-newspapers, and even the local language magazines in Tamil Nadu about this scheme. So I'm trying to advocate as much as possible based on the findings coming from the study.
Okay, thank you for that information. Ram Kumar asks, the fact that men had more of road accidents, that is trauma-related care, than women is a gendered reason for more utilization by men. Polytrauma or trauma care being more procedure intensive. So shouldn't this be discounted in the calculation of inequity?
No, there are two angles to this. Firstly, polytrauma is not included under the CMCHIS. It is reserved only to the public hospitals. So if a male or female get into a road accident, they can only access the CMCHIS scheme if they get admitted in a government hospital. So this has been an area of contention, and in generally in Tamil Nadu, mortality among men is high because of accidents. And I would say it is a gender-based difference because sometimes it's associated with alcoholism, it's associated with risk-taking, and also that male, most of the time, who fetch income for the family have to travel long distances. So it is not sex-specific. It is something that has to do with the construction of gendered role and nature of work and socialization.
Okay. I hope that answers your question, Ramkumar. You can ask a follow-up if you would like to. In the meanwhile, we'll take a question from Vaibhav, who says, what are the barriers that males encounter in accessing healthcare under the CMCHIS?
Yeah, like I put in gender intensified constraints. So all of that. So the moral hazard, for example, yes, hysterectomies threw light on the whole fact that women could be actually manipulated and they are victims of inappropriate or unnecessary healthcare. But the same could be happening for men also. So we don't know. When it happens in large scale and becomes a scandal, we take notice of it. But probably many other surgeries, even that are being done on men, are probably unnecessary and irrational. And specifically for men, again, because of migration and lack of documents, which makes them ineligible to access the scheme, is one of the major reasons. So they move from their place where they have their identity cards to different places. So the whole migrant population again have a specific barrier in accessing any of these schemes.
Okay. So we have 2 more questions, but I don't think we'll have time to address them both. Thanks everybody for the questions. The last question we can take is from Swati, who asks, can you give us an idea of how the utilization is by transgender community, if at all? Before you answer that, can we, I'd just like to thank everyone for the questions. And if there are any other questions, I think you can write to Rajalakshmi directly. Is that, yeah. So that's her email address and you can write to her directly.
Nitish, you can also pass me these questions through email. And
yes, we can. So whoever has already typed in their questions here to the group chat, I will send them across to Rajalakshmi and then she'll respond to you. Thank you. Yeah, you can go ahead.
Yeah, so the transgender community in Tamil Nadu, they do have a separate ID card and they do have access under the CMCHIS scheme irrespective of their income. But unfortunately, the claims data do not capture their third gender identity. So I was not able to analyze, but in my survey, I did find a household in which there was a transgender person and a female, a male to female transgender person. And because of that person, the entire family actually got enrolled because they can get easier access to the scheme than the others. But I felt, but I could not explore more on this, and that is one of the reasons I have put it as in the future research areas. Now, Ayushman Bharat, I don't know, it uses SECC data of 2011 where third gender were not recognized. So those will be the areas in which we need to explore further.
Okay, that's good to know.
Thanks to IPH for hosting this.
Thank you, Rajalakshmi. So let me just summarize this before we all leave. So my takeaways from this presentation were, first is gender equity in health can be defined in terms of either horizontal equity and vertical equity. So horizontal being ensuring equal access to the health resources for equal need, and vertical being enhancing the resources for unequal need. And gender-based barriers we discussed were of 3 types: gender-specific, gender-intensified, and gender-imposed. There was also a nice discussion about how men can also have some gender-specific barriers, and it'll be interesting to explore that further. But my key takeaway from this webinar and from my chats with Rajalakshmi has been that as researchers, we should take a gender-sensitive approach to health equity research, and that being gender neutral in our current context can mean being gender blind. I hope this webinar was useful and interesting to everybody. Thank you all for joining us. I really thank Rajalakshmi for agreeing to present the webinar and at such short notice also. Thanks to my whole team, Tanya, Harish and Sarin, for facilitating the webinars. And we will upload a video of this webinar soon on our website, healthinequity.com. This will be in a couple of weeks. And thanks for joining us, everybody. Thank you for also putting up with the technical difficulties that we faced in the beginning. Thank you.
Yeah, thank you.